This is First Pediatrics. Hi, everyone. My name is Chris.
And my name's Julia.
And welcome back to First Pediatrics. Whether this is your first time joining us or you're a returning listener, we're very excited to have you here today. Our topic for this episode is an introduction to pediatric sepsis, and I don't think I could have a better person to talk to leading this case. Julia, I know you've led many sepsis huddles and these discussions within our residency groups, but do you mind just introducing yourself and talking a little bit about your interest related to this topic?
Yeah, so I am currently a third-year pediatrics resident at the University of Michigan, and I have an interest in critical care medicine. Sepsis is of particular interest to me since it's something we see very commonly, and I feel like I've encountered more times than I can count on the floor. I find the pathophysiology of sepsis really interesting, and it's also something that, if spotted early and recognized early, you can intervene on, and there's really good guidelines for those interventions, and you can make a big difference in outcomes for these patients.
I think that makes so much sense. So, Julia, before we get started, could you remind our listeners about this podcast?
Absolutely. So First Pediatrics is a peer-to-peer podcast geared toward pediatric resident education. Our goal is to address your first management experiences by bringing you evidence-based content to help you on the wards and to help make daily life more manageable as a resident.
Thanks, Julia. Are you ready to get started with the case?
Sure, let's get started. So you are assuming care of a 9-year-old male. He has a history of cerebral palsy, seizures, shunted hydrocephalus, and he came to the emergency department today with increased worker breathing. You're the night resident and you're receiving handoff from the ED about this patient, and they tell you that they started him on maintenance IV fluids. He was febrile and received acetaminophen, and he also was started on ceftriaxone for a UTI found on his initial lab work. He was tachypnic and he was started on 1-liter nasal cannula. So now you have received sign out from the emergency department and you're getting ready to go down and see him. What are the sort of things that you're thinking about, Chris, that you want to know about him?
Sure. So probably the HPI, right? Like what's bringing him here today to the emergency department and what his courses look like for the past few days.
Yeah, so both parents are at bedside and they let you know that over the last several days, he's had increased worker breathing, increased secretions. Today was his first fever. The highest it got was 102 Fahrenheit. He got some acetaminophen. That improved the fever. He also had some increased tone and seems to be uncomfortable. And parents note that this is really unusual for him to be crying and seeming to be in a lot of pain. He doesn't have any sick contacts and no history of recent infections. He's tolerating all of his medications and hasn't missed any doses.
Okay, so it sounds like he's getting sick. Any notable positives or negatives on review of system for him?
Yeah, he had a really unremarkable review of systems otherwise. He doesn't have any changes in urine output, no emesis, no concern for recent aspiration events, no diarrhea or constipation, no new rashes, no increased seizure frequency, and he's G-tube fed and he's tolerating his feeds.
Okay. To round out the history, could you give us the birth history, past medical, surgical, family, any meds he's on, and immunization status too?
Yeah, so in terms of birth history, he was born at term, labor was protracted. Surgical history, he had his VP shunt placement when he was about 3, has never had problems with shunt failure, and he had his G-tube placed 2 years ago. No other medical history other than what we've already discussed, and no significant family history. Medications, he's on albuterol when he's sick only. He takes that every 4 hours, which parents have been doing for the last 2 days around the clock. He takes baclofen through his G-tube, cetirizine, famotidine, Keppra, and a multivitamin. He's up to date on all of his immunizations, including COVID and influenza.
So it seems like he's done the best he can to protect himself. Just as a general sense, I'd like to know their vitals to start off.
Yeah, so looking at his vitals, his temperature is 37.9 Celsius. Blood pressure is 98/60. His heart rate is 150. His respiratory rate is 32. And his O2 is 91% on 1-liter nasal cannula off the wall.
So there seems to be some things here that I'm worried about. He does seem to be breathing fast. 32 is pretty quick for how old he is. Remind us how old he is again. 9, right?
He's 9.
Yeah. And, his heart rate at 150, that is quite elevated as well. And he also has like a borderline fever as well.
Yeah, and one of the other things that stuck out to me was his blood pressure to 98/60. Looking back at his chart, though, you notice that this is very consistent for him at all of his well visits, all of his regularly scheduled appointments. That's where his blood pressure is. And you verify with parents that that's his regular blood pressure, and that's reflected in previous visits as well when he's been healthy. And Chris, when you're thinking about the exam for this patient and looking at him, are there anything in particular that you're wanting to make sure that you look for on exam?
Yeah. Knowing he has some abnormalities on his vitals, I'd want to evaluate his mental status first. So getting a sense of if he's confused or if he's able to communicate with us as he would typically at his baseline. I'd want to be able to elicit his strength and his tone, get a sense of if he's vigorous, is he's crying, or is he appearing tired or limp, as I'd be much more concerned in those situations. I would also want to make sure I do a good belly and skin exam, as he might not be able to help us differentiate between areas of pain and infection since he's nonverbal.
Yeah, I totally agree, Chris. And I would also be looking for all of those things. So to just summarize pertinent positives on his exam, the first thing you notice when you walk into the room is that he just seems very uncomfortable. He's tense. He's intermittently crying, but consolable by his parents who are at the bedside. He appears small for age. He's non-ambulatory, which is his baseline, and also nonverbal, which is his baseline. Cardiovascular exam, he's tachycardic with a regular rhythm. Pulmonary exam, he does have some increased work of breathing with some mild retractions. He's tachypnic. And when you listen to him, you hear diffuse wheezing and rhonchi. His abdomen is very soft, non-distended. It seems to be diffusely tender. It's a little bit hard to kind of suss out just because he just generally seems very uncomfortable even prior to examining him. From a musculoskeletal standpoint, he does have contractures in all extremities, which are baseline per parent. From a neurological standpoint, he does have increased tone pretty diffusely, but parents tell you that they feel that right now his tone is at his baseline, and the remainder of his examination is unremarkable.
Okay. Julia, I'm also thinking since they're coming from the emergency department, we probably already have a number of labs to review and maybe other studies. Is there anything that you might be able to share with us just to see where we are in the workup?
Certainly, yeah. So you look through his workup that he's had so far in the ED. He had a chest x-ray, which did not show any focal consolidation. It looked pretty consistent with a viral process. He had a respiratory panel positive for RSV. They got a UA, which showed 500 of Luc esterase, no nitrates, no glucose or ketones, and he had 10 to 25 white blood cells per high power field. A urine culture was sent based off of this. They got a venous blood gas with a pH of 7.4, a CO2 of 38, a bicarb of 25, and a lactate of 3.5. His CBC showed an elevated white count from his baseline. It was 11.7 with a baseline of 6. His other cell lines looked normal and at his baseline. His comprehensive panel was unremarkable. His CRP was elevated at 9.6. His procalcitonin was 0.06. And the emergency department also sent a blood culture, which is in process when you see him. So, Chris, thinking about all these labs, is there anything that is standing out to you or making you think differently about your differential for this patient?
Sure. So at this time, we do know a few things: that he tested positive for RSV, meaning either a current or prior infection. The UA does look infectious at this time. The VBG had a lactate of 3.5, which is not normal. And his white blood cell count and CRP were both elevated. I would say I'm most concerned about a UTI and possibly ascending pyelonephritis, as well as a concurrent viral pneumonia. But I can't say for certain, though, that we don't have another bacterial source of infection, such as a pneumonia, meningitis, endocarditis, even something like appendicitis. Based on his constellation of symptoms, though, I would actually say I'm most concerned about something like sepsis. Now, before we get to sepsis, I think it's worth talking about SIRS, which is really the precursor to sepsis, which stands for Systemic Inflammatory Response Syndrome. Would you mind helping to explain what SIRS is, Julia, and the criteria we use to define it?
Absolutely. So SIRS is essentially an exaggerated, as you said, inflammatory response, not necessarily due to an infection. It could be due to any insult.
Okay.
There's four criteria for SIRS. And if you meet two of the criteria, by definition, you have SIRS. So we'll just go through those four. So the first one is hyperthermia or hypothermia. The second one is tachycardia or bradycardia. The third one is tachypnea. And the fourth one is elevated or depressed leukocyte count.
Okay. Of course, sepsis is what I said I was concerned about. How do you get to sepsis from SIRS?
Yeah, so once we determine that a patient meets SIRS criteria, the next question is, do they have a known or a suspected infection? Because if they have that plus SIRS, they meet criteria for sepsis.
So if anyone meets two of the four criteria and you think they have an infection, you would say that they're septic.
Correct.
Okay. There's a few other definitions, and I know we're going to get to them as part of the case, but when we talk about things like the severity of sepsis, like severe sepsis or septic shock, what is the characteristic or the defining features of each of those?
Yeah, so I kind of think of sepsis, the spectrum from SIRS to refractory septic shock. And kind of as you go through stepwise and you meet more criteria, you kind of move up in the sepsis severity structure that we have. So severe sepsis is kind of that next step up from sepsis. And so once you have determined a patient has sepsis, they meet criteria for severe sepsis if they also have either cardiovascular dysfunction or ARDS, or they have two or more organ systems that are dysfunctional.
Hmm.
The next kind of step up is septic shock. And so that is defined as cardiovascular dysfunction despite more than 40 cc's per kilo of IV fluids in 1 hour.
Okay.
And then the next step up from that is your refractory septic shock. And that is IV fluid resistant, which is 40 to 60 per kilo. And you could even have catecholamine resistant septic shock. And once you're getting in the realm of septic shock, refractory septic shock, these patients are in an ICU.
Okay. Before, I know you mentioned organ dysfunction as it relates to severe sepsis, that definition. So meeting sepsis criteria and then having cardiovascular dysfunction, ARDS, or evidence of organ dysfunction to two other systems. Could you help us understand what you meant by organ dysfunction?
Yeah, absolutely. So, kind of going through by systems. So, from a cardiovascular standpoint, thinking about hypotension. If you have hypotension alone, you meet definition for cardiovascular dysfunction. There's other markers of cardiovascular dysfunction, like a metabolic acidosis, an elevated lactate that's telling us that we have poor tissue perfusion and we're requiring anaerobic metabolism. If you have oliguria, which can be indicative of poor renal perfusion as a result of cardiovascular dysfunction or prolonged capillary refill. So, any two of those four things, you can meet criteria for cardiovascular dysfunction, or if you're hypotensive, that alone meets criteria. From a respiratory standpoint, needing more than 50% FiO2 to maintain your SATs, need for mechanical ventilation are things that would meet criteria for respiratory dysfunction. From a neurologic standpoint, and this is very well something you could see on the floor, is acute change in mental status, a GCS less than 11. From a hematologic standpoint, if you suspect that your patient is in DIC, that's criteria. Or if they have a thrombocytopenia of less than 80,000 or a decline of 50% from what their normal is. From a renal standpoint, looking at our creatinine of greater than 2 times the upper limit of normal, and then hepatic, looking at your total bili, if that's greater than 4 or your ALT is greater than 2 times the upper limit of normal, that those would meet criteria for hepatic dysfunction. And these are all kind of things that in the moment, if you need to, you could kind of reference, you could use a reference to kind of determine whether they meet criteria, but just very broadly thinking about looking at the patient in front of you, looking at their labs, looking at their vitals. Are you concerned about any organ system dysfunction is also really helpful to just kind of be thinking about as you're conceptualizing a patient that you're concerned about sepsis.
Now, do you want to go back to our vitals and just sort of clarify where we are within the spectrum of SIRS?
Yeah, so just to kind of remind you of their initial vitals, their temperature is 37.9, blood pressure is 110 over 80, heart rate is 150, respiratory rate is 32, and SpO2 is 91% on 1 liter nasal cannula.
Okay. I'm thinking their heart rate at 150 and their respiratory rate at 32 both seem elevated. So just based on that, they meet 2 of the 4 SIRS criteria. They do not currently have a fever. And come to think of it, they actually do have an elevation in their leukocyte count, too. It's up from 6 to 11 from their baseline. So they actually meet 3, right, of the 4 criteria.
Yeah, correct.
So I would say they meet SIRS criteria, but I'm also concerned about an infection for this patient. So I would say that they're septic.
Yeah, I would agree with that assessment.
And now I'm wondering what we do, right? Are there any guidelines that we follow once we identify that a patient is septic?
Yeah, there are. So, according to the guidelines that were released from the Surviving Sepsis campaign, within 3 hours of recognition of sepsis, you should get an IV in your patient if they don't already have one, send blood cultures, start broad spectrum antibiotics, which could be different depending on the epidemiology of your area and your institution, get a lactate, and also give a fluid bolus of 10 to 20 cc's per kilo, keeping in mind whether you think they're fluid overloaded, whether they have any underlying cardiac comorbidities. And so these are the recommendations. And just also something to note, Chris, it gets a little bit nuanced if you're in an area that does not have access to a PICU.
Okay.
So these recommendations are for patients in a hospital that have a PICU.
Okay. I think that makes a lot of sense. So this is a nice uniform way that we can approach an undifferentiated sick patient that's meeting this criteria.
Yeah, and this is kind of a nice checklist that you can go through too in your head when you're thinking through these patients.
I also want to acknowledge that established guidelines in medicine are always changing, and as it happens, new sepsis guidelines are being released as we speak. We can provide an update to this episode in the future. All right, Juliet, we're just going to go back to the case and reflecting on that checklist you just mentioned. If I remember correctly, we have gotten blood cultures and urine cultures so far, and this was all done in the emergency department. We gave a dose of ceftriaxone. We had that VBG that was collected with elevated lactate of 3.5, and they were started on maintenance IV fluids.
Yeah, that's correct. Those are all the things we've completed so far. Is there anything you can think of that we haven't done yet?
We've given fluids in the form of maintenance IV fluids, but I think this child would benefit from a bolus.
Yeah, I agree. And that is a part of the checklist that we haven't done yet. So he did receive a 20 cc per kilo bolus of normal saline and continued on the maintenance fluids. And then you recheck a set of vitals. His temperature is 38 Celsius. Blood pressure is 105 over 55. His heart rate is 115. His respiratory rate is 17. And SpO2 is 95%, still on 1 liter nasal cannula. So kind of thinking through these new vitals that you have now after you've completed everything on the surviving sepsis checklist that we talked about, what criteria does he meet? Has his criteria changed? Has he gone up a step in the ladder?
He actually seems like he's doing quite a bit better. Now he does have a fever. I know his temperature really hasn't changed much, but his heart rate and his respiratory rate are back in the normal ranges. So I'm actually feeling a little better after that bolus in how he's looking.
Yeah, definitely. He still meets sepsis criteria, but hasn't progressed to severe sepsis or septic shock. And you go back and you take a look at him and he's more comfortable appearing and his exam looks more reassuring to you. So then you step away from the bedside. You're cross-covering a lot of patients. You have a few other admissions to do. 4 hours go by and you get a page from his bedside nurse that he has not had any urine output since admission. So you go to bedside to get a little bit more history and talk to his parents, who say that he had one very small wet diaper when he first arrived to the emergency department, but nothing since then and nothing since the bolus you gave him 4 hours ago. So, Chris, is there anything that you would want to do or any way that you would want to approach this to evaluate why he isn't having any urine output?
Sure. I would want to bladder scan him just to make sure he doesn't have a full bladder. And I think in my mind, someone at this age, a full bladder capacity would be around 200, maybe a little bit more than that.
Yeah, so you get a bladder scan and he only has 30 cc's of urine in his bladder.
Okay, so that's a very small amount.
Very small, yes. And especially that he's been on IV fluids for hours now and you've given him that bolus.
Sure.
When you're in the room, you also notice he doesn't look quite as well as the last time you saw him. He seems more uncomfortable and there isn't a lot of big changes on your pulmonary or abdominal exam, but he just overall does not look as well. And his mom mentions that she thinks that he has gradually been looking worse over the last couple of hours. And she's never really seen him have an illness like this that kind of took this course and when he was acting like this during an illness. So you go ahead and get another full set of vitals while you're in the room. His temperature is 37.8 Celsius. His blood pressure is 90/45. His heart rate is 145. His respiratory rate is 17. And his SpO2 is 95% on 1 liter nasal cannula. So, Chris, what do you think about these vitals in the context of thinking about sepsis and where this child is now falling on that ladder?
Sure. So I'm again a little more worried just based on the way that he's looking. His blood pressure is a little lower than before, and his heart rate is faster. And now you also mentioned this lack of urine output, which I know was something we talked about in relation to cardiovascular dysfunction. So does he meet criteria for severe sepsis now?
Yeah, you could probably say he does, and I would say he does. He does have oliguria, and we don't have another lactate, but he did have a lactate of 3.5 when he was admitted. So this is certainly a child that I'd be very concerned that he's showing signs of cardiovascular dysfunction in his, in the context of his bigger clinical picture. So, Chris, now that you have identified that this patient meets severe sepsis criteria, what do you want to do next?
I would call a sepsis huddle.
I think that's a great idea for this patient. So for those of you who aren't familiar, in our institution, a group coming together to talk about a patient with concern for sepsis is called a sepsis huddle. Many institutions have something similar. And it's a multidisciplinary team huddle at the bedside. And the goal of the sepsis huddle is to ensure that everyone involved in the patient's care team is on the same page and operating under the same assessment to guide management for this patient. So, Chris, now that you've called the sepsis huddle and you have the team at bedside, what are things that you would recommend?
Sure. So we're definitely concerned that they're escalating and getting worse. And I think one of the things we talked about before was evaluating repeat lactate. So getting a VBG to assess the clinical status. And then in terms of interventions, because they're getting worse, I would want to broaden my antibiotic coverage to vancomycin. That's going to have coverage for MRSA and resistant strep pneumo, and then giving them another bolus. They've only received one bolus so far, and they're again tachycardic and mildly more hypotensive. So I would definitely sort of lean on those two pillars for my management approach.
I think those are excellent next steps, Chris. So you order the 20 cc per kilo bolus and the vancomycin stat. You can even also decide that you want to also broaden to cefepime to have Pseudomonas coverage. And then you get a venous blood gas, and it has a pH of 7.27, a CO2 of 37.9, and his lactate was 5.7. And just to remind our listeners, the VBG that you got about 4 or 5 hours earlier had a pH of 7.4, and his lactate was 3.5. So as you're looking at these labs, what are kind of things that you're thinking about? And is this a patient that you would feel comfortable leaving the bedside and checking in on later?
Yeah, so clearly we have some work to do. And hopefully these interventions are going to help to turn things around. But I would feel pretty uncomfortable to leave the bedside. Also knowing that, you might leave a nurse to care for this child without extra support. And just from like a comfort standpoint and collaboration, just making sure that we're all on the same page and there to support each other when a patient's very ill would be very important.
I agree. I think this is certainly a patient that I would stay at the bedside and wait for the repeat vitals to come back after the bolus. So you stay at the bedside with the patient and you get another set of vitals. His temperature is 38 Celsius. His blood pressure is 71/37, back 90/45. His heart rate is 115 from 145. His respiratory rate is 17, and his SpO2 is 95% on 1 liter nasal cannula. So you're looking at these vitals in front of you and looking at the patient who clinically doesn't seem to have improved after the bolus and the interventions that you've done. What is the next step that you would want to take for this patient?
Typically, I max out on 60 cc's per kilogram for full fluid resuscitation. So I would rely on giving more fluids at this point in time, making sure that they're not becoming clinically volume overloaded. But in this moment, there is really not a whole lot of other tools I have, but also knowing that the other tool to help with blood pressure would be having pressors or having a PICU available to me.
I would consider calling a rapid response team, which at our institution would help to facilitate getting the PICU to bedside to evaluate this patient.
Yeah, and you brought up a great point, Chris, that as you're giving your patient boluses, you're keeping a very close eye for signs of fluid overload and maybe even calling the PICU sooner if that becomes the case. But I think right now, certainly, I would call a rapid response and get the PICU to bedside to come evaluate this patient. And if you look back to our surviving sepsis guidelines, if you're still concerned about cardiovascular dysfunction, severe sepsis, or septic shock, and that's persisting after you give 40 to 60 cc's per kilo of fluids, you might want to consider escalation to pressors, which would require the PICU. So this patient right now, kind of thinking about him in context and where he's at in his illness course and thinking about our tiers of sepsis, where's he falling in now, Chris?
I think he's now, unfortunately, at the septic shock tier.
Yeah, this patient is. So we've already established he has severe sepsis. He has an elevated lactate and oliguria. He has a metabolic acidosis and is hypotensive. So all of those things, he doesn't need all of them to meet definition for cardiovascular dysfunction, but he has multiple indicators of cardiovascular dysfunction now. So you call the PICU to bedside and they take the patient to the ICU and he is started on pressors to maintain his blood pressure.
Julia, do you mind giving some more details about his course in the PICU?
Yeah, so this patient, he went to the ICU and was there for several days before he went on to develop ARDS, and he was intubated and mechanically ventilated for several days. And ultimately, the family elected to pursue comfort care, and the patient passed away in the hospital. While the outcome of this case was not what anyone would have ever hoped for, I do think it gives us a moment to pause and remember what a privilege it is to take care of children and their families, and to remind ourselves that we can honor our patients by recognizing this and acknowledging that patients can be our greatest teachers and we can take time to learn from them. And the other thing to highlight from this case is that parents are the experts on their children. And as you're going through residency and through your career, take parent concerns seriously.
Thanks, Julia. Just to summarize the big takeaways from this episode, we learned about how to approach care for a complex pediatric patient, and hopefully you now understand how to identify a septic patient, which can guide your initial management approach, including first obtaining cultures, second providing broad-spectrum antibiotics followed by fluid boluses, and obtaining labs such as a VBG for a lactate. We discussed the definition of SIRS and the spectrum of sepsis to septic shock. This case demonstrated how sepsis can progress quickly, and that you should have a low threshold to return to the bedside for a patient that meets SIRS criteria on admission. We hope you feel empowered to call a multidisciplinary team to the bedside to discuss a patient's status when you or any other member of the team is feeling concerned about a patient. Finally, we remember the patients that we have cared for that make us the providers we are today, and we thank them for being our teachers. I want to thank Julia for being our content creator for this episode, and Dr. Jody Ehrman for fact-checking this episode. That's all we have for today, and we'll see you next time on First Pediatrics.